The purpose of this video is to review steps to successfully treat shoulder slap lesions arthroscopically utilizing Smith & Nephew instrumentation and implants. The patient failed conservative treatment, resulting in an arthroscopic procedure performed in the lateral decubitus position. A posterior portal is made using a Dionix 5.5 millimeter cannula, followed by creating an anterior rotator interval portal using an arthroscopic needle for localization. Prior to making the rotator interval portal, care should be taken to confirm that the tip of the needle can touch each individual structure that will need to be addressed within the glenohumeral joint. The needle is then removed and the clear track cannula is inserted. A probe is utilized through the anterior portal to demonstrate the superior labral detachment. A 4.5 millimeter full radius Dionix shaver is utilized to debride the damaged labrum back to healthy tissue. A bleeding surface is created using a motorized shaving device to prepare the glenoid. Note the slap tear progresses posteriorly and superiorly. A final bleeding surface is demonstrated here between the superior labrum and the glenoid bone. Looking from the anterior portal posteriorly, the posterior inferior labrum is intact, but the posterior superior labrum is detached and ready for repair. A localizing needle is introduced at the anterior lateral edge of the acromion in order to enter the glenohumeral joint just anterior to the long head of the biceps and the supraspinatus rotator cuff tendon. Percutaneously, a 2.9 millimeter osteoraptor drill guide and obturator are introduced and then driven posterior to the biceps and placed on the face of the glenoid. Drill. A drill is introduced through the guide and the 2.9 millimeter osteoraptor suture anchor is introduced. A penetrating device is introduced through the anterior superior percutaneous incision to grasp a suture posterior to the biceps tendon. A crochet hook is utilized to deliver the sutures posterior to the biceps and then tied. You may choose to pass and tie the anterior sutures first rather than the posterior stitches, as I've done here. Another option is to pass both a white and black suture in tandem together and then tie individually. Care must be taken to place all knots on the back side of the labrum away from the glenohumeral joint articulation. A penetrator is reintroduced again through the percutaneous incision anterior superiorly and brought underneath the labrum just anterior to the long head of the biceps. Okay, Huck.
Completely uneventful block placement, premeditated with effective, private regulated, field control. Show. Assembly is extremely focusing field. So much of advanced blocking relaxation.
The second set of sutures are then tied anteriorly. A posterior Wilmington portal is then utilized to place an additional anchor posterior superiorly. This may be done percutaneously or through a cannula, as you see here. A 2.3 millimeter Osteoraptor anchor is placed. A penetrator device is inserted through the posterior Wilmington portal, and the suture is shuttled around the labrum. The posterior labral anchor is tied and then probed to check for stability. The arm is taken down from the balance suspension arm holder and assessed for stability and freedom of range of motion. Following the surgery, patients are advised to wear a pillow sling for 4 weeks and a regular sling for an additional 2 weeks. Therapy is started at approximately 1 to 2 weeks after surgery. Active range of motion begins at 6 weeks. The patient is transitioned to a strength training program at 12 weeks postoperatively.